Give a talk. This is a very précis of a talk that I was asked to give last year at the National Conference for Vein Surgery and Vascular Surgery called the Vascular Surgical Society. And I was asked to speak because at the moment, as you probably know, in England, very few people have pelvic veins treated at all. Since we started publishing our work in 2000, an awful lot of people in America have taken it on, and so now a lot of research is actually done outside this country apart from this unit. So I was asked to, the rest of the vascular surgeons in the UK are suddenly wanting to catch up, and so they asked me to talk about who should be treated and who could be treated. So, as I say, this is a very foreshortened thing as an introduction. The most important thing is there's two sorts, when you hear about pelvic veins, there's two sorts of pelvic vein pathologies. There's one where the pelvic vein's closed and it's squashed and so blood can't get through it. That's called this sort of congestion, where it's blocked. And David, our radiologist who will be talking later, does this as well, but it's not what we're talking about tonight. So those are blocked veins. What we're talking tonight is about pelvic vein reflux, and that's when the valves don't work. Now, when I went to medical school, basically, if you had a male who had pelvic vein reflux, in other words, the veins were not working very well in the pelvis, the only thing they could get was varicose veins around their testicles, which is called varicocele. And in females, they thought that it didn't matter. They thought you might get a thing called pelvic congestion syndrome, but nobody really understood it. The Victorians had called every woman who ever complained of pain in her pelvis hysterical, because hysterical is from hyster, meaning the womb. And therefore, if she's making up all this sort of song and dance about pain in her womb, she must be hysterical. That's where the word originally came from. And of course, they were almost right. It's actually the veins around the womb that are causing the problem. And it actually is, that's what pelvic congestion syndrome is. Why does it happen? The symptoms tend to be a combination of all different things, but really what we're talking about big veins that are coming down. They go around the uterus, around the vagina, around the bladder, around the anus and rectum, out through the base of it, and if you've had a baby, quite often into the legs. So anywhere where the weight of blood can push on any of those organs or get inflamed can cause different problems. So you can get irritable bladder, irritable bowel, you can get pain and a sort of dragging sensation as this all pushes down on the pelvic floor, or as it comes down you can get hemorrhoids, or you can get vulval varicosities, or even leg varicose veins. It's all part of the same thing. It's all very understandable if you just look at the anatomy. So it's usually worse at the time of the period because the veins are dilated at that time, and it's obviously worse when you're standing up because of gravity. The other things that can happen, though, and why I got interested in it, because obviously I'm not a gynecologist, I'm a vascular surgeon. The reason I got interested is because I became well known for vein surgery back in 1999 when I did the first keyhole surgery for varicose veins. In other words, we now don't strip veins anymore, but we do them with endovenous surgery. And I brought that into the country back in March 1999. And I started getting these patients who came to see me with leg varicose veins, but when I examined them, they disappeared up into the pelvis, around the buttocks, around the area. And I was told at the time, when I was a junior, I was told, oh, don't worry, a lot of women have them, just pull them out. And they didn't actually do anything. And not surprisingly, that didn't work very well. And what was shown, right back, if you look back in the literature, right back in 1966, the first people said, actually, you can get varicose veins in the legs if you've got pelvic varicose veins. And John Hobbs in 2005 and another group in 2009 actually showed that was right. And we were already treating this from 2000, so we knew it. We just couldn't get it written up at the time because the English doctors didn't want to hear about it. When we published in 2009, we published and we showed that this is actually incredibly common. And what happens is we didn't come at this from pelvic congestion syndrome. We came at this, we left that to the gynecologist, we came at this from people with varicose veins of the legs who kept going to see us because they'd been treated loads of other places and their varicose veins kept coming back year after year after year. And we found that one of the major causes was pelvic varicose veins. And what we found is if women have had children vaginally, then 1 in 5 women who have leg varicose veins actually have got pelvic vein reflux. And if you look at all women, those who've had children, those who hadn't, is 1 in 7. So that means that if you look at normal vein clinics, NHS or private, it doesn't matter. Just look at doctors who treat people the usual English way. 1 in 7 women are having the wrong treatment because they don't have their pelvic veins done. That's one of the reasons why you always hear people say veins always come back. It's because they're not having the right treatment. We know that if you don't treat pelvic vein reflux, it can cause varicose veins, and there's 2 papers that show this, one from Lumley back in 2000 and one that we've just published recently in America. And this was the thing that I presented at the American Venous Forum, that my daughter actually did this research with us once. And what we showed is we looked at children who ladies who have never had a hysterectomy but have had children. So in other words, they have intact pelvic veins, and they have had their legs treated at least once else, somewhere else. And then they've come to us and said, all my veins have come back, can you please fix me? And when we've looked at what the other clinic did or the other hospital did that was wrong and why the veins came back, the commonest cause in over half the people is that they had had neovascular tissue. The veins had started growing back because they'd had stripping. The other half of the people, 33% of people, is because they hadn't had their pelvic veins diagnosed and treated. Then after that, we've got perforating veins, other bits and pieces. So not treating pelvic veins is the second commonest reason to get leg varicose veins back. So we've not only got pelvic congestion syndrome, we've got also leg varicose veins. We've got varicose veins in the vulva that can be smallish ones. If these aren't particularly cosmetically bad, but if they thrombose, they're terribly painful, and they can also be aching. And then, of course, the bigger they get. I've had one lady who wouldn't let me take a photograph who had a vaginal vein that was as big as a grapefruit, and it actually took us some time to get rid of that. But you can get rid of them, but it's again another sign of the problem. It has been estimated it's 4% of females, and the gynecologists say that's not very many. If you actually think that there's 70 million people in the UK, and half of them are women, that's 35 million, and 4% of those is an awful lot. So 4% might not be a lot in percentage terms, but in numbers, if you are not treating them, that's an awful lot of ladies who have problems who are not being treated at the moment. The grading system we invented back in 2012 and published it, and it's grade 1 from very simple all the way up to disfiguring and unable to pee or have sexual intercourse or wear normal clothing, which is grade 4. We've also recently been looking at something else, because at the moment, if you know about piles and hemorrhoids, they're treated by, at the moment, bowel surgeons who literally just cut the pile away and tie them off, or fry the artery, or do awful things to the bowel. And the trouble is we think they're doing the wrong operation. So we published this recently, and we showed that if you look at people who have hemorrhoids, they seem to be all related to people who have pelvic vein reflux. So we think that actually hemorrhoids are actually just another part of pelvic congestion syndrome. And there's some supporting work, because in Scandinavia, they've been looking at people who have coronary embolization for leg varicose veins, and the hemorrhoids get better in a high proportion of them. And in fact, David and Previn have also noticed this in some of our ladies who have their pelvic veins treated for their legs, then say actually their hemorrhoids have improved as well. So this is something we've been actively looking at with a thing called Hemorrhoids, and it seems that in the actual veins that are concerned go through, and it actually seems to be that hemorrhoids are just varicose veins of the anal canal, which is obvious if you're not medical, but unfortunately if you're a bowel surgeon, it's absolute heresy, because they don't want to hear that. Bowel surgeons want to think it's part of the bowel, so they can just chop it off here. But if you don't treat all of this as well, it's just going to come back. So what have we got now? The trouble is, so the medical books are all wrong at the moment, because we've now got this huge amount of things that if men have reflux in their pelvic veins, if it's the testicular veins, it's varicoceles. If it's internal iliac veins, it's hemorrhoids and leg varicose veins sometimes. And in women, there's a host of things, including pelvic congestion syndrome. And one of the reasons this is so new is because this is not in any English medical textbook at the moment. It's not really understood at all. We have until recently been the only clinic that's been looking at it. There are now some teaching hospitals that are starting to look at it. Hello, that's okay. Hi. So the question is, so that's who could be treated, so who should be treated? So at the moment, we have to look at who could be treated. So the most important thing is talking to the patient, finding out what's wrong with them, examining them, and there's very little to examine unless you see leg varicose veins or veins around the vulva. And then investigation. So the most important thing is what the investigation is, and the different ones. I'm not going to talk at length about the most important one, because you're going to have an expert talking about that in a minute. But what you could do, if you've ever been to gynecologists, you're often offered laparoscopy, venography, MRI, CT, sometimes ultrasound, and sometimes transvaginal duplex. So just to run through this, laparoscopy is rubbish because you can't see the veins. You can see cancers, you can see cysts, you can see all sorts of things, but you can't see the veins. So if you're looking for pelvic congestion syndrome, it's a useless test, and of course it's invasive and expensive, so it shouldn't be done. When we're looking at venography, MRI, CT, a lot of patients think these are incredibly high tech because the machines cost $1 million, $1.5 million, so therefore they must be good. And because they see deep inside you and you don't have to have anything stuffed inside you. And so because of that, you've got no needles or anything, it seems like they're wonderful. But the sad fact is, if you've ever seen anyone with varicose veins, if you're lying flat, you don't see varicose veins, because varicose veins only become visible when you stand up or on a slope. And all of these, you lie flat. So it's completely the wrong test, because when you're lying flat, your pelvic varicose veins are flat. And so no matter how expensive these tests are, they're the wrong tests. There's a fellow at the moment who's following our work up in Birmingham who's getting a reputation at the moment for doing lots and lots of pelvic vein treatments, and he's doing it all on MRI, and not surprisingly he's getting very strange results, because it's basically, you might as well flip a coin. So people who use this say that if your veins in the pelvis are large, if they're over 8 millimeters on MRI, CT or venography, you should treat them. And if you're lower than that, you don't have to treat them. So we've recently just published this study in the European Journal of Vascular and Endovascular Surgery. And basically what we did is we split veins into their sizes, and this was done within 0.1 of a millimeter, so incredibly fine, 0.1 of a centimeter, which is 1 millimeter, incredibly fine digital subtraction venography, so you can see exactly what the diameter was. And we split them into those that did not reflux, the valves are working, those that did reflux, proven on ultrasound. And when you actually look at it, you can see that there's no difference between the groups. And that means if you use this 8 millimeter cutoff, it means half the veins that were treated didn't need treatment, and half the veins that needed treatment didn't have it. So if you then turn around and say, oh, I've done 100 patients and I've done all this treatment to them and only half of them got better, it's not surprising, only half of them got treated. So that's why it's rubbish to look at some of these people who come and say, oh, it doesn't work or it doesn't, unless they've done it properly. If your test is wrong, it's like trying to get somewhere without a map. You can't actually see. When it comes to transabdominal duplex, it's absolutely fine. If you're sort of very nice and slim, you can see the very tops of the veins, but you can't see the bottom. But obviously in the more typical American patient, or people like myself, you just couldn't see anything low down in the thing. So therefore the only thing, and what we've developed here is this thing called transvaginal duplex ultrasound. It was invented by Judy Holdstock and Charmaine Harrison, and Angie, who'll be talking to in a minute, has been working closely with them and uses their technique. And so Angie's going to talk to you about that, because that has now been shown to be the gold standard test for this condition. And then David's going to talk to you about how it's treated. All right, that's just a brief overview. Are there any questions at the moment at all? No?
Do they always manifest in having varicose veins to the legs, or can you have issues that don't manifest themselves?
Excellent answer. Excellent question. The biggest answer is, we can't answer that for sure, because all of our original work, so we've been now doing this for 16 years, and all of our patients originally came because we were looking at leg varicose veins or vulval varicose veins, and gynecologists were ignoring what was going on in the pelvis. And when I was a medical student, we actually had a book called 10 Teachers, and what 10 Teachers said very, very clearly was that if you took 100 women, and this is how all doctors in this country are taught, if you have 100 women going with pelvic pain to the gynecologist, 30% of them need to see a psychiatrist. They shouldn't be there. Those 30% are people, almost all of those have got pelvic congestion syndrome. It's just that gynecologists don't test for it and don't look for it. The other 70% they find, endometriosis, cyst or something, and might not even be that. It might be they're just not overlooking it. So some of those also might be pelvic congestion. But the trouble is they don't even look for it. So because we don't have that number, what we can say is we can say how many are coming because of they're picked up by leg veins. We can start to see now how many people are coming for other reasons, because people have heard about our research and are coming to us. What we don't have 10,000 people who haven't had leg varicose veins but have got pelvic problems. I'll tell you one quick anecdote. There's a very famous vein surgeon in the UK who for the last 20 years has basically said everything I've done is rubbish. And when I brought in these new techniques, he's spoken wide, he's been in the press saying, you shouldn't listen to this maverick, we should still strip veins. And slowly, everything we've done has been proven right. And he came to me at one meeting, I thought, oh, it's going to be another thing. And he said, would you mind seeing my daughter? She's just got married. She can't have sex at the moment because it's so painful afterwards. It's just uncomfortable and everything, and there was nothing to see on the outside. So he came, and Judy Holdstock scanned her, all 4 veins, both ovarians, both internal iliacs. He then got embolized. Was it you or Previn? I can't remember. She got embolized, all 4 veins embolized. Never even heard back, didn't get a thank you or anything at all. I thought, well, that's fine, doctors are doctors. I heard the other day through a friend, she's just had her 7-month baby. So it was baby 7 months ago. And it's clearly worked, everything's back online. He grudgingly once said, oh, everything's fine, and that's it. But the thing, so there's, without doubt, there's a huge host of people out there with pelvic congestion syndrome. I think that the ones that we see with leg varicose veins as well are only the tip of the iceberg. The majority of people won't have leg varicose veins. That's almost the complicated ones. It's a bit like looking at, we now know that if you've got venous reflux in your legs, only some people go on to get varicose veins in the calves. If you've got varicose veins in the calves, you go to the doctor. If you don't. You just wonder why you've got heavy legs until you get your leg ulcer or your clot. So we know that the underlying cause happens a long time before you get the external thing. I think it's the same in pelvic veins. I think you've got a lot of people out there with pelvic venous congestion. They've got all sorts of problems. They're fobbed off. They're given the pill, given the coil, told all sorts of things. Oh, it's just irritable bowel. Here, take some copamine, take some peppermint water. They're told loads and loads of things, and it's only when something becomes obvious that doctors listen to them, and that's the problem. And I think, with the research that we'll do over the next 20 years, it's going to keep me to my death, and probably not quite to David's. He's much younger than me, but basically, as the research goes on, we will understand this much more. And we, like all diseases, we're treating the worst ones first because we see them, and then as they sort of go forward, we'll get to the more subtle ones.
I can say I also work in the NHS, and I do a lot of gynae scanning, and just anecdotally, I do see a lot of patients that do have isolated pelvic venous congestion, and I ask them, do you have any noticeable anything on your legs or anything anywhere else? And no, they don't. I mean, that's just in my observation.
Have they ever been treated for pelvic floor congestion?
They have not, because the NHS doesn't quite treat as many as...
I think we must say right from the outset, this is not NHS versus private, because the NHS doctors tend to be, they work 4.5 days a week NHS and 1.5 days a week private, and they work hard. It's 6 days a week job, which is standard for most doctors, and they work evenings as well. So everyone works hard. It's a knowledge base. And what happens, most doctors will only do what is recognised because they're scared of being sued, they're scared of doing anything wrong, and it's an incredibly conservative profession. Nobody likes going out there inventing something new. When somebody else is taking the risk, they all like to be first to do it in the country, but nobody likes to be first. So basically what happens is, it's at the moment, if you go privately for symptoms of pelvic congestion syndrome, you've probably got the same chance of treatment if you go NHS. There's very, very little difference between it. There have been some cases done in the NHS because we've referred them back and they've been coped with. But it's, again, the key to this is getting to have the service together, which is the ultrasound that you're going to hear about, the embolization, and the standards. What we're doing, we're running courses to try and teach people. There's a group that we've got together along with Boston Scientific to lobby the government. So we're not trying to just say it's only the Whiteley Clinic, it's saying use our research so that everybody can get this.
I guess what I'm really asking though is, I'm not playing devil's advocate here, I'm playing it for my other half who's had problems, and what I'm trying to get at here is, irrespective of whether it's in this country or not, is there any empirical evidence coming out anywhere that someone has been treated or numerous people have been treated specifically for the gynecological reason, not for leg reasons, and they've shown improvement?
Sorry, yes, I misunderstood you. I thought you were talking about general figures. The answer is yes, and in fact we've got one of our patients is actually very kindly going to talk today. So once we've done the scientific bit, so we're going to have Heather's going to talk to us about her own personal experience. In fact, that's exactly why an awful lot of our patients are now being treated. We're trying to get figures on that, and we're trying to get, because the biggest problem they've got at the moment, there's some papers that say it works incredibly well and the results of 50 to 60% improvement. Some say 90% improvement, and it depends where it is. The biggest trouble with those is almost nobody is using the right test, so you might as well toss a coin. When we have somebody who has been investigated for everything, can't find anything else, has clear pelvic congestion syndrome on pelvic, then the chance of success is very, very high. But if you're looking at it from a population point of view, that's what we can't do.
How many do you find who go into puberty? Do you get any in that age group, or is that really rare?
That's such an interesting question. That's exactly the sort of thing we want to answer, and science hasn't moved on that far enough. Because the test is a transvaginal duplex ultrasound, if it was a blood test, it would have been done by now, but it's quite an invasive and personal test. And because of that, we only ever scan people who come to us with symptoms or we find the veins going to. We don't just go out and scan people willy-nilly, even with ethics committee at the moment. So the population studies just haven't been done. So we don't even know about in adults yet, never mind how it is. It was only in 1994 where I did the first study looking at children with leg varicose veins. And I was a senior registrar at the time in Reading, and I got 2 school children to do it for their A-level project. We got into all the newspapers and everything. And it was because we showed that varicose veins come much earlier than people think if you look for them inside without actually looking on the outside. So we know with leg varicose veins it's happening by the age of 9 in 1 in 20 girls. So the chances are before puberty you have got the reflux because it's the same genes. But the chance of finding that in the next 10 years, I mean, it took me a year to get ethics committee just to look at the legs. And I didn't even look at them, I got the girls to. But
Today, I mean, I deal with young adults. There are girls that are in so much abdominal pain, and it doesn't have to always relate to their monthly period. And I know a couple of girls, they literally are dosed up to the nines with painkillers, and they've got no life.
No.
And they keep going back to the doctors, and they just...
And they'll almost always be written off at the end of the day with endometriosis, even if they can't find any, because it's a dustbin diagnosis. And it's one of the things I always say, when I give international talks, I make people laugh a lot, because I say that one of the things about being an English male, we all hate being 11, because when you're 11, you go to school, you walk in front of a strange doctor, you drop your trousers, you turn your head and you cough, and every male hates it. And they're looking for 3 things. They're looking for a varicose vein retrotesticle, they're looking for a hernia, and they're looking for whether you've got 2 testicles, and they're checking all those 3 things. Girls, they don't do it because you can't see anything. But the most important thing is for every boy who gets picked up with a varicocele, and there are a hell of a lot of them, there's a girl who's got pelvic congestion syndrome. So all those girls at the same stage have already got pelvic congestion syndrome when boys are being picked up with varicoceles. Boys get sent off for treatment because you can see it. Girls get told, oh, you're just a woman, that's what happens, don't you know? And that's the unfair side of it, you see.
Yeah, because she's not having, you know, I know a few of them, they're not having
what would be nicer if we could actually get a less invasive investigation. Angie's now going to tell you all about the duplex ultrasound scan that we can diagnose, at least that's it. The next thing after this is finding a better test, obviously.
Right, okay, so I'm Angie White. I'm one of the sonographers here at the Whiteley Clinic. So a little bit of what Professor Whiteley talked about is some of the symptoms. So the throbbing and aching in the lower back, which gets worse over the day, especially if you've been standing, can only be relieved if you lay down and elevate your legs.